Hello, Don here. Welcome to Podiatry Practice Mastery, where we're helping you get your practice to the $1 million mark and beyond. I'm going to be sharing kind of what was working for me today. This is a recording of a Tuesday, so let's kind of get into it. First patient was a Lamisil follow-up. So just a reminder, so for my Lamisils, I usually do 2 visits. I used to do 3. So I used to do like a nail sample on every one, see them back, and then go right into the terbinafine. But now I tend to skip that first one, and I go Lamisil 3 months later, then do like a booster. Only because I found a lot of recurrence when I didn't do that. And then most of my patients, they get my fungal kit, if you've heard about that before. So they get a UV light and the shoe spray. I've had people ask me, like, how do they do both? Well, one person said, well, no one will ever get the UV light. I just make it kind of a package, and it makes it a lot easier. So on my treatment sheets, on there you'll see there's like a kind of a protocol that I use. So I have them do the terbinafine, I have them do the biotin, I have them do and I explain how to do it. So biotin's daily, terbinafine's daily, UV light is weekly, and then the shoe spray, UV light is monthly, and the shoe spray is weekly. So I have it all kind of set out for them, and I also tell them all this together is about $200, and it's just a one-time thing. So that's how I do it. I'm trying to add more topical to kind of this, because I think there's a lot of patients that aren't wanting the oral, and I haven't been doing topical. I just have a hard belief pad. I don't believe it, the topicals that much. So I'm trying to get better. So once again, if any of you guys love topicals and they don't have to use it forever, let me know. Also, same thing with laser. I feel like the same thing with laser. I feel like it's something that you're using it forever, like our topicals forever. And how do you get around that mental hang up of having them use it forever and not really getting cured? Is it like you're just preventing it from getting worse? I'm just trying to understand how other people think about these things. If you have any thoughts, shoot me an email, don@podiatrypracticemastery.com. I'd love to hear that. Next patient was a 67-year-old female. She's a new patient. She had really, really bad heel pain. So plantar fasciitis, a little bit of Achilles. So when someone has like pain, like an 8, 9, or a 10, like they're limping around, I'm tending to recommend cortisone, only because they can't really tolerate the shock wave. So this woman, she came in, she was just in super amount of pain. So I did x-rays, ultrasound, and then ultrasound guided cortisone injection, and then she got my the Pelto special, which is a night splint, foam rolling, and morning stretch. So same thing, I have a kit for the fungus, I have a kit for heel, plantar fasciitis, and Achilles tendonitis, which includes a foam roller and a night splint. So she got this, and she's going to come back in about 3 weeks. I'll see how she's doing. And then I told her most likely if the pain's better, we'll do an orthotic to help correct the mechanics. And then if it's not better, then we'll plan on switching her a few weeks after for shockwave. Okay, next patient was a 73-year-old. Same thing, status post Lamisil. I debrided one nail, and I recommended for that really thick nail to do Cara nail gel. I don't think he got it as he was exiting, and I want to say about the bad thing. I heard my office, like kind of the person at checkout, talk to them, and he said, "Oh yeah, this is like $60. I don't know how it works. I don't know how to apply it." So I feel like it's like my fault for not really training them how to do that stuff better, how to like explain these types of products to them. So I feel like we need to add that to one of our trainings for our staff again. Next patient was a patient, 38-year-old female. She has bilateral bunions. One's quite painful, first ray elevatus. Talked to her about surgical, non-surgical. I think in the end she'll need surgery, but right now she has 2 young kids, so I tend to explain to patients, you have to find the right time for this. And she opted for a cortisone injection to that joint, and then I'm going to see her back in a couple weeks, see how that is doing. If that calms things down, then most likely I gave her shoe recommendations and maybe an orthotic when she comes back for that first ray elevatus that's causing some joint jamming, and like the hallux limitus that she has in conjunction. And then she could schedule the surgery at a future date. I think she would benefit most due to her young age from a lapidus. Next patient was a 85-year-old female, had a recurrent ingrown toenail, good pulses, so I did a matrixectomy on her. She'll do a 3-week follow-up. Next was a 58-year-old gentleman. He was seen a few weeks ago for plantar fasciitis. That was painful. I did an injection, and he's feeling much better. He also needed to be seen for nail care, so I'm going to see him back in 3 months with my assistant for nail care. Next was a 40-year-old female. She came in for she has a wart. She didn't really want treated, but she also had cariflex on her left hallux, so we did this cariflex for her. There was a patient that came in somehow in my nail care. I don't know, she came in for nail care. I'm not sure how she got in there, but she was scheduled, and I'm going to see her back on my nail care day. I did do the nail care. Next patient was a 68-year-old female. She had a callus between the 4th and 5th, so 4th, 5th toes, kind of like an exostosis, or just like a prominent bone from the toes rubbing, kissing corns. And I talked to her about, I trimmed it down. I talked to her about possibly doing an arthroplasty of that toe to reduce the rubbing. I talked to her also about shoe changes, like anatomic shoes. She also had a thick toenail, so I did a nail sample, and I'm going to see her back in 3 weeks. And so just kind of the rationale for this. So I usually go straight for the terbinafine if patients are there only for that condition. If they have something else going on, for example, those kissing corns, I talked to her about that, got x-rays for that, to not spend a ton of extra time. That's why I did the nail sample, just because otherwise it would have taken me more time to do the oral terbinafine, and I just didn't want to overwhelm her on the first visit. I just want to explain why sometimes I don't do directly to Lamisil the first time, especially if I'm doing like multiple issues. I'll do the nail sample. It gives me a little bit more time, and I was going to see her back anyway for the other condition. Next patient was a 69-year-old female that was seen for neuropathy. Kind of thought she had neuropathic pain. I don't deal with a lot of neuropathy. I would love to know if someone is really good at dealing with neuropathy. I'm using Qutenza. Sometimes I'll do some gabapentin. If anyone has any other great tips that work for you, shoot me an email, don@podiatrypracticemastery.com. I'd love to either interview you or we can talk kind of about what's working for you for neuropathic pain. If you have a good process, I know some people use like MLS lasers and night splints and all these other things. I've talked to a couple of people that just love neuropathy. I don't love neuropathy, but if other people have other things that are working for you, please let me know so I can share it with others, so I can learn, but I can also help other people here. Next was a 78-year-old gentleman. He was concerned he had gout. He did have some warm swelling in his left big toe joint. I've been seeing a lot of gout lately. I don't know why. It's the summer, maybe dehydration, but I did Colchris for him. I got x-rays, and I'm going to see him back as needed. I don't tend to give that out a lot, but I gave it again. Next patient was a 59-year-old that came back for a Lamisil booster appointment, so a 3-month follow-up. They're going to follow up as needed. Then starting the afternoon, there was a patient that came in, 72-year-old gentleman. He had thick nail. I think I debrided that nail. His PCP sent him over, and he really didn't care about his nails. He just came here because his doctor told him to come here. So I'm not going to see him back. He doesn't really need or want any treatment. Next patient was this is kind of interesting. He's a 69-year-old gentleman. He has bilateral like hallux limitus, really bad arthritis with the first MPJ. And on the right side, he had like a cyst / like callus on the top of the big toe joint. I thought it was maybe there was spurring dorsally that was rubbing on the shoe. So he has a big like callus in there with a kind of like a soft tissue mass. He was concerned if it was like cancer or something like that. I don't think it is, but I biopsied that. So I gave him 2 options. We could either remove the thing or we can biopsy it. So I did 2 2mm punch biopsies for this, and I'm going to see him back in a couple of weeks to go over that. I also took a nail sample. He had a possible fungal toenail, so I did a nail sample. So I'm going to go over all that stuff next time. Usually when I biopsy, I do 1 cc of Lido with epi, and I do 2 2mm punch biopsies. EMR update. It's getting a little bit easier in my medical record now to document all this stuff. Next patient was she had left foot pain. She had previously had heel pain. I did a cortisone injection. And then she had like midfoot pain, and I did a cortisone injection. That didn't really take that well, and she is having a lot of pain, and she's not really sure what's going on. So I did I ordered an MRI for her just to kind of see if there's anything, because her x-rays don't look like there's a bad arthritis in the midfoot, but that's where her pain is mostly. Next patient was a 38-year-old. She's a female. She did better with diflucan, so she failed terbinafine, put her on diflucan. She's doing better. I renewed it again. She has proximal nail clearing, but she also has some plantar fasciitis. And I don't know if you have some of these patients. There's certain patients we have that just, it seems like they don't ever want to invest in their health, like basically spend money. And this was one of them. And she did one cortisone injection, got a little bit better. She didn't want another cortisone. I talked to her. I think she had a thick plantar fascia. I think she'd do best with shockwave, but she's not really sure she wants to do that. And I think it's mostly financial. I just find there's a certain demographic that tends to not want to do anything that except what's covered by insurance. And so I just feel like they don't get better. And in these ones, I don't have the most patience. I try to be patient, but I don't have the most patience for them. So sometimes I'll extend the follow-ups. I'll just come back as needed, or do it 3 months or something like that until they're ready to take action so they can get themselves better. Next patient was a 51-year-old. She had kind of a third digit that was swollen. She injured it, possibly from running, possibly doing something else. I think it'll get better over time. I got x-rays. I didn't really see anything abnormal, so I'm going to see her back as needed. Next was another patient that had bilateral onycholysis and thickening of his toenails, and one of them cracked off. So he was concerned, came because it cracked. It was attached to the proximal third of the nail bilaterally on those big toes. And I talked to him about it. He's not too concerned about the nails. He was just concerned that it cracked. I just told him to keep his nails trimmed short. He's not really interested in treating the fungus, so I didn't do that. He was concerned about, as the nail grows back, it might grow in, and I explained to him about the T-taping, which is the taping that can be done if there's bulbous changes at the top of the toe. Next patient was a 69-year-old. He came in for drop foot. I don't treat a lot of drop foot. I recommended a posterior spring AFO for him. He had insurance. I would have to send him out. He had Blue Cross Blue Shield, so I have to send those out to Hanger. And he also had a peroneal nerve release by a nerve person in California. So I don't know if it was a neurologist or probably a neurosurgeon. And he got a little bit more dorsiflexin back, he thinks. So I don't really know any great treatments for that. He was wanting if a back doctor could do anything. So I gave him a suggestion for a back doctor. Next patient was a 58-year-old that had an IND of the left hallux, and then another add-on patient that had a carry-flex. She wanted a carry-flex, so I did that. Yep, so that was the day. Once again, you can see kind of repetitive, but I guess no. So the drawback here was no orthotics this day. But I did have some good patients. It was kind of a smooth day, and we're getting better at our medical record. We're struggling with one thing now of how to communicate to the front office when people want to buy things with ModMed. So we have ModMed, for example, they're going to buy a foam roller, or they're going to buy a cream, or they're going to buy something else. I don't walk patients out anymore. I don't have any paper I give them. It's usually all electronic. So I'm trying to figure out a good way to communicate to the front office staff. There's not really a great tickler system like Athena had. So I'm still trying to figure out that. If you guys use Athena and you have good ways of doing that, let me know down at podiatrypracticemastery.com. Once again, hope you guys enjoyed this. If you have other things that are working for you, please shoot me a message, and I'll be happy to share them with the rest of everyone listening.